have heart failure again. Our lungs are going to be affected, our liver, our kidneys. He's probably going to get diabetes. He will lose all of his hearing. He will lose his eyesight. But I never heard that from Colton, did I? Well, did I have it? No. It's good to know though, huh? Because what did we start doing?
Braille. We started learning Braille. Do you like your Braille?
So it kind of changed
Colton
our...
gave me a really nice Christmas card in Braille. I'm gonna cherish forever.
But
So do you think? How do you think we have the healthcare system represented here in all the segments? And this is an amazing odyssey. And I wasn't smart to realize it was Alzheimer's syndrome because I've never been taught that. But I knew something wasn't right, and I was very moved by your perseverance and patience. And I felt like the least we could do is rethink the whole constellation of things that he has suffered. So we're going to work really hard to make it better.
And that's, I think, my biggest thing is I'm very proactive. Same with Dr. Chang is don't think inside the box. Just because he had that testing done already once, he encouraged us, let's go do it. And we had that relationship that I'm like, okay, if you think we should do it again, we'll do it again. Times change, and there's so much medical literature coming out every single day that I understand that physicians cannot read all the literature that's coming out every day, but if there's some kind of intelligence database that we could put all that information into, because I truly, truly believe if we were still in Ohio, we would not have a diagnosis to this day. And I would never know. And that's pretty scary because I know there's lots of other families out there facing the same thing.
Well, about a third to half of the syndromes in pediatrics are either delayed or never diagnosed. So unfortunately, you are one of the third or half. Unfortunately for us, you're no longer. So can we give them a round of applause for being up here? He's really enjoying being admired by 500 people. So why don't you stay on stage? I'll just finish up our first session. As some of you know, I have two lovely daughters and had a personal journey myself into healthcare with my daughter Emma having heart surgery. It was a very, very tough month for us. And this was my home for about 2.5, 3 weeks at the hospital. And, you know, as even a casual observer in that setting, you really see all the deficiencies firsthand, and unfortunately quite frequently, and this is one of the top hospitals in the country. So as if that wasn't enough for the year, about 2.5 weeks ago, I got short of breath after a trip. After we wrapped AIMED Australia, I came back, and to make a very long story short, of course it was the one morning I couldn't find my stethoscope that I usually carry in my briefcase. And fortunately, here's a little plug for wearable technology, especially for clinicians. I have my cardiac device in my pocket, and did a 6-lead EKG on myself, and realized, because I have this bothersome resting tachycardia, and as my mentors and as I always teach others, resting tachycardia is never good. So I would try to rehydrate, and then heart rate stayed up in the 120s, 130s. And the EKG showed a complete right bundle branch block that was entirely new for me. So in my mind, as the clinician and as a potential patient, I kind of put everything together and said, recent trip to Australia, shortness of breath, complete right bundle branch block, I think I have a PE. So I Ubered up to the local hospital, and they were waiting, because I'm on staff at the hospital. They had a CTA waiting for me. So the good news is that I didn't have a pulmonary embolus, but when I listened to myself with the ER physician stethoscope, I realized I had a full gallop and either tricuspid or mitral regurgitation, which is entirely new for me. So here's my, I never thought I would show my own echocardiogram at a meeting. But here's my echocardiogram, and even the uninitiated can tell that there's a lot of blood going back in the left atrium. And the left atrium is twice the size of normal. So I got ambulanced up to my former colleague and friend, Dr. von Starnes, who's one of the world's preeminent heart surgeons, who, very matter of fact, told me when I called him up and said I'm in a bit of trouble, explained to him what I had, and he said, "Come on up, let me take care of you," in just those few words, and got ambulanced up. Now, during the, for those of you, how many people have actually been in the back of an ambulance as a patient? Okay, very few, about 5 or 10. First of all, it's very uncomfortable being in that gurney. I didn't realize how uncomfortable. You know what? The shortness of breath, and basically pulmonary edema, for those of you who don't know as a clinician, you're basically drowning in your own lung fluid, and it's very hard to exchange air. I'm on oxygen, trying to sit up and breathe, and my competent EMTs in the ambulance were just casually chatting like I wasn't in the ambulance, talking about the interesting transports they've done in the last month or two with amazing detail that I didn't need to hear about. They were chatting about what taco place to go to after they dropped me off. I just sat there incredulously that they were discussing all this, and they knew I was a cardiologist. And so it went on and on. For, it was a long ride. It was an hour and a half to 2 hours up to USC. But I was just so struck by the lack of situational awareness. And that was actually the worst part of the transport. So that was myself in the ICU setting on about 10 drips. I was much sicker than I thought I would be. And Vaughn didn't think I was going to be this sick either, so I kind of, very lucky that this didn't happen while I was traveling back from Australia. So for that, I was eternally grateful. And in addition to my family that I was working hard to get back to, this meeting was literally 10 days down the road as I got out of the ICU. So I basically made my rehab schedule about a quarter to what it should have been, and really worked hard in the hospital to get back to you. So this was discharge day. I remember this picture very fondly because the rest of the world was very well intentioned in saying that this is the meeting I'm going to have to miss this year. And you know, this is not about the slides, this is about the people and the friends and the colleagues we've made. And I really wanted to be here. This team was convinced I was going to make it back here. So they proved the rest of the world wrong. So, yes. Like I mentioned in the newsletter, one observation for our data scientists, friends, and AI experts who probably have never been a patient. All the terminologies that you see here are the ones I experienced during my stay. And they all mean different things, obviously, but they all have different weights in terms of suffering and pain. And I made the words bigger if it was more significant or more painful for me. And please remember that these are not strings and numbers. These are actually the patients pay a dear price to give you that data. So ultimately, they should own the data. And we're just privileged stakeholders in managing the data. So my observations with both my daughter and myself, I humbly submit that AI is still vastly underleveraged in clinical medicine. You heard not just Colton's story, but my own stories, especially to relieve the clinician burden. And in 2019, I'm still seeing clinicians copying down lab data onto sheets of paper that I did when I was in training. So 30-some years, we really have not changed that dramatically. in terms of how we manage data. Now, it's true that we've gone electronic, but we're not really leveraging that very, very important transition. That data are not simply numbers and strings. These involve suffering of our friends and colleagues and families, and that sometimes there's a lot of criticism about machines not allowing us to be human, or that machines need to be human. And I don't mean to be always defending the machines, but I think we humans can learn from the machines too, and perhaps have situational silence and just be functional when we need to be. And we don't have sometimes that situation awareness. So because of this amazing year and the fact that I got here, I want to pay a musical tribute. And thank you, by the way, for all those of you who submitted pictures and opened the meeting this year with a special tribute to patients and families that we have the privilege of serving, but also the doctors and nurses and healthcare workers and administrators that work so hard to get us out of the hospital. So it's a musical tribute. We're going to have a transition after the music tribute because I'm pretty sure I won't be able to say anything, so we're going to bring up the next panel at the end of the tribute and the transition. You ready? introduce Nessun Dorma and the music behind the tribute. As a cardiologist and intensivist, I've lost many nights of sleep, and I know some of you are in that domain as well. So Nessun Dorma is a piece from Turandot, which means never sleep, which is very apropos. But also realize it's not only the doctors and nurses don't sleep, the patients with all the testing and everything almost never get any sleep either. So very appropriate that we made a tribute to all people in healthcare. Well, I've been looking forward to this session for a long time because we have a star-studded panel here. And we're going to start off with Ted. It's been 5 years since you were here with us last time. I know we spent some time together afterwards. But he has, having been at the very beginning of what I consider the era of AI in healthcare and medicine in the 1970s with his pioneering work at Stanford, looking at expert systems, trying to figure out how to incorporate that, and then have been a very active follower as well as progenitor in this space and often writes editorials. I just thought 5 years would be an interesting time to bring Ted back and give us the right perspective. And he's not only a mentor for me, but also a friend. So those people are very rare in life, but they're both. So with that, I'm going to introduce Ted.
Yes.
We built the stage so that you can sit if you like to talk. You can walk a platform like a rock star if you want to.
This is a perfectly comfortable place. It's hard to follow that amazing opening session. Congratulations for that. My task for this first talk, I'm giving another one on Saturday, was to cover the history of artificial intelligence in 15 minutes. That's no small charge, as you might imagine, so I'm going to rush through but try to give you a feel, especially for the medical side of AI. You may know that this is not a new field at all. In fact, the name artificial intelligence was made up in about 1956 at a meeting at Dartmouth by a computer scientist named John McCarthy. It stuck. Some people have regretted that that was the word he made up, but I think now it's kind of part of our vernacular and culture, and no one questions it anymore, despite this augmented intelligence concept that you discussed last night. Do I control the slides? No. So here's what I'd like to try to do today in this brief amount of time. I'd like to make it clear that medical AI today is really in the middle of a long trajectory. It certainly isn't over, but it isn't new either, and yet we're at a particularly exciting inflection point. Much of what we're able to do today and the excitement today is because the ideas that might be somewhat older are finally able to be realized and achieved because of the remarkable changes in computing technology, everything from the cloud to parallelism and the like, much faster processors, much more memory, everything getting cheaper. And suddenly ideas that were kind of impossible to implement, even though they were pretty well founded, are now really coming into blossom. So I'll try and give you a sense of where we are in that evolution. The article that you mentioned that I published in JAMA last year is actually the subject of the final talk, not this one. So I'll lead up to that, and we'll finish that next Saturday. You know, when people first started thinking about using computers in medicine, the focus was largely on decision making and how computers might help us make better decisions. Especially diagnosis. I remember people saying, when you're doing work with computers, you mean so people can punch in their symptoms and get a diagnosis back. That was in the 1970s and 60s, the first instinct people had about how computers might play a role in healthcare. Obviously, we've done a lot of other things with computers in healthcare, so much more successfully with decision support in the intervening years. But in the area of decision support, there's been a lot of evolution, and there's been a recognition of the importance of data, information, and the knowledge that one can derive from those, and the representation of all those concepts in computers. And most physicians actually acknowledge that they could use some help for the very reasons we've been talking about in the last hour, but it has to be done in a way that they find acceptable. And there's been a lot of difficulty in making that possible. And what is a proper way of offering decision support is actually a major topic, and it's evolved a lot over the years, and it's still probably one of the major impediments to a lot of direct physician use of computer-based decision support and AI. So I want to emphasize a point that should be clear. We don't call computers doing this kind of work decision makers, we call them sources of decision support. The implication being that the long-held relationship between doctors and patients should not be interfered with by this kind of technology, but rather we should supplement the ability of the physician to still have those kind of relationships with patients and at the same time have enhanced access to the information and the diagnostic support and the therapeutic support that they need. In the 1950s, there actually was early work in this precise area, and most people, in fact, can point back to a single article that was published in the late 1950s as the start of computers in medical decision support. It was published in Science, using foundations of medical diagnosis, and it's fascinating to go back and get that article and read it even today and see how people at that point, Ledley and Lustig, were imagining this future and the use of computers for this purpose. They focused on Bayes' theorem. They recognized there was a probabilistic aspect to decision making, and especially in diagnosis, and that you could certainly implement and carry out the calculation for Bayes' theorem in computers, even as they existed in the late 1950s and early 60s. But it was pretty hard to imagine that people were in the real world using Bayes' theorem in any sense. And so there was a movement by the end of the 1960s to say, look, we have to be thinking differently about how computers can help with decision making. There's something more going on in the heads of people than simply calculating with numbers. Clearly that's the nature of the actual therapeutic and diagnostic interaction with patients and their data. So in the 60s and 70s, there was a lot of work on